We'd like to move ahead to our next session, which is a debate session. Our chairperson is Dr. R. Sekhar. May we have you on the stage, please? Dr. R. Sekhar. May we have you on the stage? And this session is titled as Controversies in Venous Practice. Controversies in Venous Practice. This session is chaired by Dr. R. Sekhar. The stage is all yours, sir. Over to you. May we applaud for Dr. R. Sekhar here. Thank you so much.
Yeah, good evening. So this being the last session for the day, I feel this is probably the most interesting session for the day. Two topics which are extremely relevant to our day-to-day practice. Controversies in venous practice, absolutely appropriately named. So we start with the first of the two debates. First one is thrombolysis in iliofemoral DVT, very controversial. We have two speakers. Dr. Sairam will speak for, and Dr. Prakash Ramurthy will speak against. I'll share with you the rules of the engagement. 8 minutes for each speaker, followed by 2 minutes each for rebuttal, and then we'll have about 5 minutes for discussion. So without wasting much time, I would invite Dr. Sairam on stage. He'll be speaking on thrombolysis in iliofemoral DVT. He'll be speaking for the motion.
Thank you, sir. So at the outset, thanks to the CMC team for inviting me for this talk. So almost 50% of patients who have iliofemoral DVT and are treated with standard anticoagulation tend to develop post-thrombotic syndrome. Almost 1 in 4 of them will have pretty bad symptoms, and almost 6 to 10% can develop venous ulcers. So that's probably because standard anticoagulation tends to leave a lot of thrombus behind. And hence the trend towards trying to open up the vein. So there are various ways by which the vein is opened up. So it usually involves some amount of thrombolysis along with different thrombectomy devices. And then there are endovascular adjuncts such as angioplasty and stenting. All of these are aimed at keeping the vein open. So overall, if you look at all these different strategies, they are all pretty effective with more than 80% success. And most are safe. The newer trials describe risk of bleed of only about 1.5%. So why are we debating here? The whole crux of the debate really is, do these interventions prevent PTS at all? So our knowledge comes from two large trials. The first is the CAVEN trial. So this was published in 2012, 209 patients. This is basically CDT versus anticoagulation. And their mean CDT time was 2.5 days, which is pretty long. And hence they had a 9% risk of bleed. But most of the bleeds were all just related to the access site. And no endovascular adjuncts were used for this trial. So in the CAVEN trial, they looked at PTS at 24 months, and they showed that there was a 14% absolute risk reduction for the group which had CDT. So the same cohort then underwent a 5-year follow-up, and in the 5-year follow-up, there was a 28% improvement in risk of developing PTS. So obviously what they've shown is that if you follow these patients long enough, you will then start identifying more and more PTS in the control group, and hopefully less PTS in those who had intervention. So the CAVEN trial concluded that you could use additional CDT for those who have proximal DVT. Then came the ATTRACT trial. The ATTRACT trial was published in 2017. And here they basically used anticoagulation versus PMT. The ATTRACT trial, however, also included the femoral and popliteal DVT patients, along with the ilofemoral ones, and there was a 24-month follow-up. So in the ATTRACT trial, the primary efficacy outcome was to look at overall PTS, and in that the trial could not show benefit for the PMT arm. But if you look at the other bit of data from the ATTRACT trial, they showed clearly that in terms of symptoms, the PCDT group had much improved scores compared to the control group. Also, even the PTS group, the moderate PTS, that was statistically significantly less in the PCDT group compared to the control group. So the ATTRACT trial showed that intervention might not prevent mild PTS, but it does prevent the worst forms of PTS. So, but the ATTRACT, in the initial publication included FemPop as well as ilofemoral DVT. Then they did a subgroup analysis on the ilofemoral DVT patients, and the results were quite similar. So again, if you look at PTS overall, it's not different. Definitely severe PTS as well as symptoms are much better in the PCDT group. So ATTRACT tells us that with intervention, you can actually prevent venous ulcers and bad symptomatic PTS. So, but this is about 25% of PTS. So we probably should be looking at the group which is going to be at high risk of developing this amount of severe PTS, and then concentrating our efforts at intervention for that group. So there have been various trials on that, and they've tried to identify factors which could influence the PTS severity. One of them is younger age, and then how severe the symptoms are when the patient presents to us. Also probably how the patients respond to your initial anticoagulation. These are all factors which might influence this patient's further course. So in those where we identify high-risk factors, we should probably go in for intervention. When you do the intervention, you get excellent veins, but you don't get the same kind of statistical correlation with PTS prevention. Why is that? So the one main problem is we don't have scoring systems which identify PTS very well. The ones that we have tends to overdiagnose mild PTS, and most of the trials end at 24 months. So you need a longer study. 5 years is probably minimum, and we don't have that yet. So is there a need for intervention in acute ilofemoral DVT? Definitely yes. Do we have safe and effective techniques to intervene? Yes. And does intervention prevent bad PTS? It definitely does. So we should offer CDT or PMT for ilofemoral DVT, especially to the young and fit patients, those who have low risk of bleed, and those who probably have high risk factors for developing severe PTS. Thank you very much.
Thank you, Dr. Sairam. That was an excellent presentation. Dr. Ramamurthy, please come on stage. You can have it.
Good evening, everybody.
Speaking against thrombolysis.
Good evening, everybody. I'm going to purely talk from an Indian perspective because I think most of the data we are presenting here is from the west. It's always west. In the Indian scenario, the logistics are different. The pressure on the treating physician is totally different. So we have a lot of other factors to think here. And I'll just quickly go through. See, for thrombolysis, we need a correct patient, the appropriate level of suitability for thrombolysis. Then you need the patient to come at appropriate timing. See, most of the time the patients come quite late, they may not be suitable. Then affordability, because basically one factor which Sairam has conveniently mentioned, not mentioned, is the expense. It's a very, very expensive procedure with, repeated trips back to the C-arm and imaging and repeated this thing. And acceptability. See, I think one thing which we are not very, very truthful in the patient, towards the patient's attender, is we are not telling them all the complications. You may say, the risk of bleeding is only 2%, 3%. The thing is, this person may be the one which falls in the 2%. And if you tell them all the risks, I don't think anyone will be really willing to go for thrombolysis, actually. Okay, can you have the first slide? Oh, I can. So, as Sairam has also already mentioned, when successful catheter-directed thrombolysis can relieve obstruction, maintain valve function, preserve QOL. Just to mention, I do refer patients for thrombolysis. I don't do thrombolysis myself because of various, I'm a freelancer and I don't have the time and patience to sit in one hospital, tracking these patients. I offer thrombolysis only when the patient is in phlegmasia. Otherwise, I don't go for thrombolysis. And if it is left side, definitely yes. Because most of the time after the patient has had a thrombolysis, you may probably uncover a iliac vein stenosis which may be suitable for stenting. So my criteria is very, very simple. If the patient is in phlegmasia, then definitely yes. If the patient has got a left-sided phlegmasia, definitely yes. Just to say that I'm not against thrombolysis. I do send patients for thrombolysis to one of my interventional colleague in one of the local hospitals. So, as mentioned, the factors against thrombolysis, the technique has been associated with prolonged infusion times, large doses of plasminogen activators, and potential for bleeding complications. So, the bleeding complication, as mentioned, can be very simple, like local hematomas, or can be. Slide is not moving. Yeah. And another factor which I think all of the other modalities of intervention to be combined with thrombolysis is becoming more and more. So you have thrombus aspiration models, then percutaneous thrombectomy. So all these additional procedures add to the time and cost. And another thing which, the high risk of pulmonary embolism, and definitely all these patients who are going to undergo thrombolysis for a major clot burden, they'll definitely need a placement of IV filter. And this must be removed as early as possible. Again, putting filter one cost and another cost. So all these factors in the Indian scenario is very, very, very crucial because we have, even without any of these modalities, patients can spend, so much money. And when you take up these patients for thrombolysis, the amount goes higher and higher. Again, safety issues. I'm just quoting a paper which actually studied many other papers, and compared with anticoagulation, catheter-directed thrombolysis shows a significant increase in the occurrence of complications. This is one of the important findings from this study. And significant bleeding risk. So 3 studies reported minor and major bleeding, and pooled results showed the same results, that catheter-directed thrombolysis has a significant increase in the occurrence of minor and major bleeding compared with anticoagulation. So we've been using anticoagulation for many, many years, and patients have been doing well. So is it really useful? The latest antithrombotic therapy for VT chest guidelines notes the balance of risks and benefits with catheter-directed thrombolysis uncertain. So we have been used to the, treating these patients with anticoagulation, and of course, the patients do develop, post-thrombotic syndrome, and as Saira mentioned, whether thrombolysis really prevents post-thrombotic syndrome in the long run is something which is not yet clear. So taking all this into consideration, is the procedure safe? I would say the procedure definitely not safe. Is it cost effective? No. Especially in big cities like Mumbai, I don't know what the bills run into. And mostly important, is it something which you can suggest on your friends and family? I definitely wouldn't go for this thing. So the question I would want to ask the audience is, will you suggest it to your family if a patient comes to you? Keeping in mind, any patient out of 100, only 1 or 2 patients can develop fatal intracranial hematomas. That could be your particular patient. And the question I want to ask Dr. Shekhar, if Aishwarya Rai came to you tomorrow with major DVT, will you advise her catheter-directed thrombolysis? So with these questions, the main concern is bleeding. That's the main thing. Expense, of course, leave. In the Western model, everything is paid for by the insurance. In the NHS, everything is paid for by the NHS. But here, everything is paid for by you, if you don't have insurance, or by the insurance companies. And so all this you need to take into consideration. And the main thing, we don't want to cut a sorry figure. We have had patients, die and, attenders blocking the road, attacking the hospital. So this is my main worry. I want to sleep peacefully at night, and I don't want to go for all the risks associated with thrombolysis. I would rather put the patient on anticoagulation and sleep peacefully at night. And of course, all these patients, if you think they have a high risk for pulmonary embolism, definitely you can put an IVC filter, which is not a very, very dangerous procedure. But thrombolysis, no. Thank you.
Okay. So thank you, Dr. Ramurthy. We'll have 2 minutes rebuttal from Dr. Sairam.
Right, so thanks, Dr. Prakash. So a few things. Cost, yes, obviously is an issue. So if someone's going to sell the property and get this procedure done, I don't think it's really worth that. But if someone can afford it and is young and fit and fits the other criteria, then we should offer them intervention. Bleeding risk from CDT, especially when you add PMT techniques to it, is actually exceedingly less, 1% or slightly more. So it's not more than that. Fatal bleeding does not occur, and no trial has actually reported fatal bleeds. So bleeding risk, I don't think is an issue. IVC filters are not required for CDT if you're doing it for iliofemoral DVT, unless there is thrombus in the IVC, or if you're using angiojet, then probably there is a need for putting in IVC filters. But otherwise, IVC filters are not required. Friends and family, if it's a 30-year-old cousin, then yes. 60-year-old uncle, then no.
Right. Thank you. So before we actually go into discussion, just for the sake of interest, I'd like to, let's have a show of hands. We have a limited audience, but how many of you at the end of this debate, or even before, would be for thrombolysis in iliofemoral DVT? How many of you would be for iliofemoral DVT, thrombolysis, for thrombolysis? Okay, and how many of you would be against? Yeah, and how many are you? How many of you are maybe? So basically, I think there is a trend towards being more in favor. But we'll have a discussion. So anyone who would like to put their point of view around, Dr. Malay.
The thrombolysis, basically, if we break it down into, reduction of the thrombus burden, and then thrombolysis, or simple thrombolysis, catheter-directed thrombolysis, which is the simplest form, or you want a reduction in thrombus and then short duration thrombolysis, like some of you know that we in Gujarat, most of us follow a short duration thrombolysis after thromboaspiration. So it all depends upon how you take it and how you do it. As far as IVC filters are concerned, we almost never used it. I haven't heard anybody from Gujarat use it. So that's one point. So as far as the ATTRACT trial is concerned, it being quoted the most as so many flaws. In fact, they had even one stent that was 14 millimeters placed inside the vein. It was an arterial stent placed inside the vein, got thrombosed, and of course then you're going to have the poorest of the poor results. So, probably it's not a good baseline to say, well, somebody else may have a similar viewpoint or a different viewpoint. Of course, Shekhar may also have his own viewpoint. I think he has to use his privilege as the chair at the end of the concluding remarks.
Dr. Ilekma here.
Yeah.
Continuing with what Dr. Malay Patel said, ATTRACT trial had its flaws. One major problem with the ATTRACT trial is the short period of follow-up. That is 1 to 2 years. That is a very short time for evaluating for PTS. As you know, most of the PTS, majority, occurs beyond 2 to 5 years, right? So that was one of the drawbacks and flaws that was inherent in Vedantam's ATTRACT trial. So probably they have an extended follow-up, then probably we know whether it is really beneficial in preventing PTS.
Yeah, correct. Dr. Pinjala, any Any opinion on thrombolysis?
I think everybody comments on that track saying that there are flaws in it, there are flaws in it. The people who conduct the trial would definitely have gone through all the details. The only problem I see with the track trial is they have combined iliofemoral with femoropopliteal venous thrombosis segments. They should have been separated. Probably the analysis could be done separately to assess exactly iliofemoral, the results are better. But at this moment, unless we do more trials, we cannot recommend to the large population thrombolytic therapy.
Yeah, I think if I have to conclude, Dr. Malay, yeah?
No, I just, you know, looking at, well, ATTRACT trial was done after some internal games were played, and then they started the trial. So basically, this is the inside story. Anyway, so what does intuition tell us? Intuition tells us that the clot burden has to be removed as quickly as possible. How you do it is in your safest hands. Sometimes, you know, it defies logic, like Evra trial. Now, aren't we taught all along medical school that treat the pathology first or as soon as possible so that the ulcer heals? So you have to do an Evra trial to do that? I mean, I don't say this on international fora, but it just makes common sense to, you know, sometimes do that.
Yeah.
At this moment, we do not choose the anticoagulant based upon the clot burden. Clot burden can reduce with rivaroxaban also. They have done a trial where they compared large clot burden, minimal clot burden. The response to rivaroxaban was just the same. So based upon the clot burden, we don't have trials to say, choose this anticoagulant, choose that anticoagulant. Clot burden can be dissolved with any type of anticoagulant.
Yeah, I think the only thing is the period which it takes to reduce that clot burden. I think the whole essence of thrombolysis is to try and preserve the valvular function. So that is, I think, what is the basic funda of that. But I think, you know, at the end of the day, I think we can keep debating this till the next conference. You know, as they say, till the cows get home. I think the jury is still out. As Dr. Sairam has said, you know, there is an interesting study which says that the quality of life study which they have done says that, you know, doing a thrombolysis at the end of the day doesn't improve the quality of life. But then he has put his justification saying that probably the ways in which we evaluate quality of life have not been validated. So that really, you know, it's a kind of a googly which he has thrown. So I think, as I said, you know, the jury is still out, and we'll keep debating this till probably the next couple of meetings. Thank you very much for both the speakers. I think we have had an excellent kind of a session. I hope. Thank you.
Keep the same debate after 2 years.
Yeah. So we quickly get on to the next debate on perforator incompetence in CVI, to treat or to wait. So before we start, let's have a show of hands. How many of you, when you see perforator incompetence in CVI, how many of you would treat right away? How many of you would wait? How many of you would treat right away? You have a CVI with perforator. Yeah. So, right. Okay. So, yeah, I presume, yeah. Anyway, we'll get to the talk, and then probably we'll get the justification for doing or not doing. So for the motion, Dr. Bedi, please come and deliver your talk, 8 minutes.
Good evening, everyone. Thank you for making the two of us the last speakers. I'll be speaking on for the motion, perforator incompetence in chronic venous insufficiency. No disclosures. Now, that's one of the earliest incompetent pathological perforator that I treated. This is more than 20 years back, and now we no longer, you can see what an angry looking lesion it is. So that is what a incompetent pathological perforator looks like. And actually, what is it? This is the clear-cut definition, size, and the duration of reflux, which we all know, plus if it is located near a healed or an active ulcer, that makes it a pathological perforator. So why treat perforators? There is substantial evidence of the role of incompetent perforators in advanced CVI. Two-thirds of these patients will have a pathological perforator, and the treatment of such a pathological perforator is now recognized that for C4 and to C6 disease, it definitely helps in quicker recovery. And it should only be offered to those patients, obviously, where the symptoms can be attributed to the incompetent perforator and not just the presence of the perforator. So one of the earliest trials was the SCHAR trial, which indirectly, not directly, did tell us that treating a reason for an incompetent perforator, although there were very limited cases, would help you in ulcer healing. And after that, there were a large number of trials, beginning with the open surgery, which I showed you earlier, followed by SCPC, the subfacial endoscopic perforator surgery, which was very successful. I'll quickly go through these trials because all of them show the same results. So this is so many trials in the Journal of Vascular Surgery, European Surgery, Phlebology, and basically all of them tell us that the healing of the ulcer is better and recurrence rate is lower if you treat the incompetent pathological perforator. Similarly with foam therapy, which is also quite effective. And then we moved on to RFA, endovenous ablations. Number of trials, RFA, laser, and even with glue, and again, all of them show the same thing. This is a combination of trials, about 13 trials, which show that if you treat that pathological perforator, ulcer healing is improved from 50 to 100%, ulcers will heal, and recurrence will happen much less, that is 0 to 23%. And so there is, at the moment, no convincing evidence for the role of treatment of even a pathological perforator in C2 and C3 disease. And in C5, C6, for conservatively if you want, then you should treat it only after the truncal reflux has been treated. And this is a trial which, a study which compared all three endovenous ablations, laser, RFA, and foam, and recently even glue has been tried, but not in large numbers, and all of them showed the same thing: quicker healing, slower recurrence. Open surgery and SCPS are no longer done. So basically what are we doing is basically a spot welding. So there is a small area which is, and the treatment procedure is very, very standardized, whether you do RFA or you do laser. And I'll also, rather than debating, I'll just tell you what I feel should be done, how I decide to ablate a refluxing perforator. Please understand, I'm emphasizing on a pathological refluxing perforator, not just you see a perforator on ultrasound, you don't straight away go to treat it. First is that it should be pathological, and we've classified what you call a pathological perforator: size more than 3.5 and refluxing for more than 500 milliseconds. And if it is located near a ulcer, that makes it very, very pathological. So even if it is pathological, but the patient is asymptomatic, obviously we don't treat that. In symptomatic patient with a pathological perforator, I would first treat the correctable source of reflux, correct the truncal reflux, reassess at 4 to 6 weeks, and then if it is still not recovering, the ulcer is not healing, and the perforator is still there, then we would close it by whichever technique we are comfortable with. Except, primarily, if the ulcer is very large, which is subjective, it's recurrent, and if it's medial, and it remains, you've already treated the truncal reflux, and it's still there, so there you would be straight away going and treating the perforator. Also, you must see the overall picture. Is there associated edema or inflammation, obviously ulceration, and a treatable truncal reflux, if it is there, that should be factored into your consideration for deciding the line of therapy. So there are some hotspots, there are some technical points for treating a perforator, and the treatment is very standardized, the hardware is very standardized. Some additional points that you should watch for adjacent artery, that's very close to it. Ensure, of course, that the deep system is patent. There is always a fear of creating a DVT, which is slightly more than if you don't treat it. So that one has to be careful about that. And of course, if there is an open ulcer or an infected area, you should not go through that infected area. So choose the patient carefully, treat the truncal incompetence first, and then you have multiple options, whichever you are comfortable with. Open surgery and SCPS is no longer done. And you must also understand the physiology. That is, these perforators are not appendixes. They help maintain the hemodynamic balance, and you should treat them only when they are pathological and they are contributing to the disease. So in advanced CVI, I would treat an incompetent pathological perforator. Thank you.
Dr. Ilay Kumar, 8 minutes.
Okay. Good evening, once and all. First of all, I like to thank the organizing committee for giving me this opportunity to present this topic. I have no disclosures to make, except for the fact that I heard someone say that the best way to win an argument with Dr. Bedi sir is to avoid one. So he has made my job easy. I think it's not. Can I move this? Green, okay. Right. So, as we know, perforators connect the superficial with the deep system. We have the whole lot of perforator groups, above knee, below knee, medial, lateral, anterior, posterior. And we traditionally are taught that when we ablate the GSV, the perforators along the, particularly the medial group, will spontaneously disappear, while the lateral group as well as the posterior group do not, mostly. And looking at this article by Resek C, it looks at the impact of the calf perforators on the venous hemodynamics in primary varicose veins. Here, in case of saphenous reflex, the bidirectional flow within the calf perforators has a distinct inward vector towards the deep veins. So this inward component is more pronounced the more larger the saphenous reflex. So incompetent perforators do not cause ambulatory venous hypertension. So exactly the opposite happens. So the size of the calf perforators is determined by the amount of saphenous reflex, and if the saphenous reflex is abolished by any procedure, the enlarged calf perforators should diminish. So keep this article in mind. So why should we routinely do a perforator ligation? Is it necessary? This paper by Robert Mendes from the Journal of Vascular Surgery 2003 looks at some retrospective data, and they also looked at certain hemodynamic profile in these patients who had superficial venous reflex, like they did in APG, and where certain parameters like venous volume, filling index, everything was noted. And then they ablated the saphenous vein, and also they did phlebectomy also. They found postoperatively, when they followed up the patients, the superficial and perforated incompetence, there was an improvement in the hemodynamic parameters, and the clinical symptom score also improved after superficial ablative surgery alone, suggesting ligation of the perforator veins can be reserved for patients with persistent incompetent vessels or with abnormal hemodynamic parameters. This is another paper by M.S. Goel. He is a co-author in the ESCA trial. So he recruited a patient from the ESCA trial, same treatment, compression bandaging alone. or compression plus superficial venous surgery. So the SCAR trial, like that similar results in the, like in the SCAR trial, they came to the conclusion that after surgery, the presence of an IPV doesn't have an influence on the ulcer healing rate as well as recurrence. So adding any procedure like SEPS to your superficial ablative surgery doesn't improve the quality of life nor prevent recurrence. This is another topic by another study by Thomas Donnell in the Journal of Vascular Surgery 2008. They looked at various trials, and again they found two trials was analyzed here. In this trial, GSE ablation alone compared with compression. And this was continued as the Dutch ulcer trial, where surgical treatment of IPV was also done, resulted in 83% healing with 22% recurrence rate of the ulcer, while compression alone gives 73% healing and 23% ulcer recurrence. They found no level 1 evidence to support IPV treatment alone affects ulcer healing or recurrence. And so, can phlebectomy be deferred? Like Dr. Rahul said, yes, this study was also done, where varicosities were marked. RFA was done for the GSV alone. They left the varicose incompetent perforators, followed it up routinely with duplex examination. And they found that complete varicose vein resolution was 41% in the above knee and 25% below knee. For the above knee varicose vein, 88% were located medially, so highlighting our previous wisdom. And all the reserved ones were medial varicose veins. Thus, great saphenous vein ablation resulted in subsequent resolution or regression of many lower limb vesical veins. As Sir said, the AVF guidelines are very clear about what to treat the pathological perforators. But the US vigorous guidelines added, for most patients with varicose vein without skin changes, treatment of incompetent lower leg perforators is not recommended. And for patients with advanced skin changes with isolated or residual incompetent perforator veins thought to be significant, treatment may be considered. And they come to be reference. To summarize, the presence of IPV alone does not justify its interruption, and the decision to intervene should be based on clinical judgment and the specific IPV in the overall hemodynamic picture of the limb, since occlusion of the IPV doesn't influence the venous pressure. While contrary to that, elimination of saphenous reflex alone has a profound hemodynamic effect with the reversal of incompetence in the untreated segment. Even though up to 58% of the IPVs incompetence will reverse up to 2 years after surgery. Even if they persist after 2 years, they have a questionable impact on the status of the limb. So, gentlemen, so which path to choose? I side with our President, Dr. H.S. Bedi. So, we choose the middle path. Definitely, we have to treat what we should treat and wait for some cases which are not indicated. Thank you.
Thank you, Ilya Kumar. Have a seat. Dr. Bedi, 2 minutes rebuttal, if you have any.
I think you chose the wrong people. Me and my distinguished colleagues agree on the indications. I a little bit more aggressively. So I think we both agree that in advanced disease, that is CBI, if there is an ulcer, which and you can show definitely that the pathological perforator is contributing to the ulcer, then obviously it should be treated. And as I myself said, in C2, C3, even if it's pathological, we would not be treating that. Thank you.
Yes, thank you, Dr. Bedi. I think the consensus is like, Indians stand on Ukraine, the middle path, right? Neither here nor there. Okay, so we quickly get into discussion. Anyone in the audience who would like to add to what you already discussed, or Dr. Pinjala?
I think both the speakers very carefully treaded their path. The words they use, pathological reflex, what does it mean? We want to differentiate perforators into re-entry perforators and reflexing perforators. Would you like to do intervention in re-entry perforators? That is what the question is. The question is not about the reflexing perforators in C5, C6. So will you routinely deal with the patients with perforators, re-entry perforators, irrespective of their size and the reflexing material?
Anyone else who would like to?
See, that depends on how you define that. You know, it's not very easy for yourself or your radiologist to, exactly besides these two, the duration and the size. Whether it's a re-entry or it's an overload perforator, that may be difficult to, diagnose. So we would not really know. So the best would be to first treat the truncal reflux, which is treatable, wait for 4 to 6 weeks, and then go.
I agree with sir. Most of these will settle down. This reflex will reverse if we treat the axial reflex. So we wait for some time. Some may continue up to 1 year, or even up to 2 years. It may take for the reflex to completely reverse. So I don't think we have to go ahead with intervening in such special situation. So it is not a general rule that applies to all type of perforators. So is the specific IPV, is it contributing to any ulcer or skin pigmentation changes? Then I think we can manage conservatively.
Yeah, just another, question which always comes in the mind in the clinical practice, besides what we have already discussed. You see a patient where the ulcer is not healing and it's very slow healing. And clinically, if you make the patient stand, you will not see any veins because it's all, the skin is very thick and you don't see the veins. But when you do an ultrasound, you find a huge number of veins which are present at the base of the ulcer, on the peri-ulcer area. And when you check the reflux, there is no reflux in that. So now, but the amount of veins which are there are huge, like number of veins on ultrasound, what you see, which you don't see in the subcutaneous place on an ultrasound, like normally. So what we have observed is that in some patients where the ulcers are not healing, your perforators are there, and number of veins in the, at the base of the ulcer, and still there is no reflux. We treat them with foam. And imagine you do 1 4-layer bandage on that, in 2 weeks the ulcer heals up. So, I'm just putting in another question mark area there, that not every time, what science is showing and what clinical picture is showing. And I think it's a venous pressure which is there and which is not reflexing, also helps in healing.
I think that's very correct, and what we have to look for is not just the anatomy, because there are 150 perforators, known perforators, in each leg. So you are not justified in hunting all of them. It's only if one, it is pathological, two, it is functionally causing the problem. So I agree with you there.
So I think I'll quickly wind up by asking each of the speakers, say, I'll give you a situation. You have a venous ulcer around the malleolus, which has been around for a couple of years. You have a truncal reflux. You have a pathological, a peri-ulcer reflux more than 0.5, and the diameter of your perforator is about 4. Would you treat right away, or would you ablate the truncal and wait with compression? I would ask this to both of you, so if each of you could just reply one after the other.
Yeah, if it's C6, which you're saying
C6,
it is,
yeah.
and I'm doing a truncal ablation with whichever procedure, whichever modality I'm comfortable with, I would ablate the perforator also.
Same. Even the ESUS 2022 guidelines has a similar scenario. So either it can be done concomitantly or also, but the thing is it has to be ablated.
Yeah, so that is what exactly is the debate actually. If you see slightly different wording, it's not CVI. What the debate actually in essence tries to bring out is, or whoever has made this topic, is that you have a C5 or C6 or a 4B, C4B. You have the pathological, what is pathological, what is not pathological has been clearly defined. There's no ambiguity on that if you see the AVF guidelines. So would you only treat the truncal ablation and wait for the ulcer, or would you simultaneously also ablate the perforator at the same go? That is what is contentious, I think, because once upon a time when I really was presenting a paper on this, I asked 10 people in Mumbai about how they would treat such a scenario, and you'll be surprised that, about 7, each of them had a different take on it. So it just goes to say that, still there is no consensus. There are many ways to skin a cat.
If I like to add, sir, considering the Indian scenario, so multiple procedures, the costs involved,
Yeah.
and the anesthetic requirement, if any.
Yes. So,
Right?
that
So
would be
there's
one
also-
major reason why I would
we-
treat it at the same sitting. But I'm
So I
sure
will
there are
take it
people.
the same sitting also.
There are many people who would probably treat it secondarily. Yeah. Thank you. So I think that was a
Thank
good
you.
kind of a discussion. Thank you both speakers. And thank you audience.